Hi, everyone. Good evening. Good evening, everyone. I am coming your way again. This is the second video on physiological integrity, basic care, and comfort. I had talked about mobility and immobility. Today, I'm going to talk about conditions limiting mobility. This is under basic care of comfort. Physiological integrity is the main heading under the test report on the candidate performance report, what NCLEX expect you to know. So these are topics I tackle them based on the category that you are being graded for. So I finished another video about basic care and comfort, mobility and immobility. The second part of this is conditions limiting mobility. So as the nurse, what are the conditions you think will limit the patient from moving around? What are the problems that you think will limit your patient from having them freely move? Ideally, we all know and you all agree with me that you want to have patients that are able to move around. That's the aim. I had mentioned in another video that the aim of every nurse is to have the patient to be more independent. You don't want the patients to depend on you for everything, every basic need. So let's talk about basic care and comfort conditions that limit mobility. So we'll start with herniated intervertebral disc. Herniated intervertebral disc. When you assess a patient who has this condition, you will see a low back pain. They will describe a knife-like pain. They will say it's like somebody is poking a knife in the middle of my back. There will be lack of muscle tone, poor posture of body mechanics. The patient cannot stand upright, which is not supposed to be the normal. So standing upright will be a problem. Then we'll have sensory changes. Then diagnosis. When you are diagnosing a patient with this problem, what do you expect to see? The diagnostic procedures, what do you expect will be the procedures that will be ordered to diagnose this patient with this herniated intervertebral disc? So the diagnostic testing that will be done will be computerized tomography. It will be magnetic resonance imaging, MRI. It will be myelography. This one is a procedure where you encourage the patient to take a lot of fluid. You encourage them to increase their fluid, keep head of bed elevated 30 degrees to reduce the risk of seizure. So they put something and then they get a graft in the bone. Then we have discogram. They use a non-invasive procedure to view the disc of the patient, just like ultrasound. So we have surgical procedures that will be performed on patients who have herniated intervertebral disc is going to be laminectomy. So this one, excision of a portion of the lamina to expose the affected disc for removal. So in this surgery, usually this is a neurosurgery. It's usually done in the neuro unit. So the neurosurgeon will go inside the patient's back and then they mark a circle and then they cut to expose the area that is affected. They would have done the diagnostic testing to know where the problem is. So they count the disc on your vertebral column and then they get to that particular one that is diseased. And then they incise inside it to expose the disc that has the problem and they cut it out. That's the procedure, laminectomy, cutting a portion of the lamina. So laminectomy with infusion, this involves several discs. Operation includes use of bone graft to strengthen the vertebral column. So they had to do a bone graft in this procedure. Minimally invasive surgery. So they have minimally invasive surgery. So this one is the microdiscotomy interbody cage infusion. Now the plan or the implementation for this, what is the plan for this, or what will you do for a patient who is having this procedure done? So preoperatively, you know that this is like a surgical procedure. So for a patient undergoing surgery, you want to prepare them preoperatively. So preoperative preparation is necessary. You apply moist heat to the site. You put the client in Fowler's position with moderate hip and knee flexion. You have them flex their hips and their knees. Then you use firm mattress, bedboard, firm mattress or a bedboard, or floor for back support, something that will support their back. Isometric exercise for abdominal muscles, daily exercise program. Then you have the you assist with exercise that are initiated in physical therapy. So if the patient has to go for physical therapy for that, you have to assist in the physical therapy exercise. Then pain medication, muscle relaxants, NSAIDs, and analgesics. So you also want to help the patient in traction. So if the patient is in traction, you separate vertebrae to relieve pressure on the nerves. Then we have the transcutaneous electrical nerve stimulation. So this one is the use of electrical waves to stimulate the patient's nerves. This is to increase mobility. Remember, we're talking about conditions that affect mobility. So we have the post-operative, after the operation. If they finish the operation, you want to maintain body alignment. You lock roll every 2 hours with pillow between legs. And then you provide calf exercise on their feet, their calves. You provide calf exercise. You assess for sensation and circulatory status, especially of lower extremity. Remember, they went into the patient vertebra in the back. So you are worried about the lower extremities because there has to be connection, there has to be flow. So you want to keep assessing the patient's legs. That's why you provide a calf checks, and then you provide lock roll, you turn the leg, cross the legs, and then you roll the patient on one side. You put pillows in between the legs, ensure that the circulation, you want to assess circulation on both feet. Monitor eliminations, check and see if the patient is able to move bowels. Remember, I said again, is invasion to the lower back in the vertebral column. So if a surgery is performed there, you're worried about the nerves. So you support the neck after cervical laminectomy, straight back during ambulation. And then client teaching, what will you teach this client about? You teach them about daily exercise, but you avoid strenuous exercise. You can't have them strain too much. So you teach them about correct postures all the time. They need to maintain correct postures. Avoid prolonged sitting, standing, walking, driving, and then rest intervals, rest in between activities. Then you use a hardboard or firm mattress for bed. So you tell them they need to change their bed. It can no longer be the soft foam. They need a harder and a firm surface. You avoid the prone position. So you tell them to avoid lying in the prone position. Then you also avoid straining or lifting heavy objects. Now, evaluation, what will you see when you evaluate the patient? What did you want to achieve as the nurse? So when you evaluate a patient who has gone through this surgery or a patient diagnosed with this herniated disc, you want to have complications to be prevented. Complications like walking, loss of function of the lower extremities, bowel disorders, and all those things. Does the client understand the teaching? So you're teaching them about post-operative measurement, exercise daily, rest in between, avoiding strenuous exercise, and all those things. Do they understand? That's your evaluation. So when you are doing an evaluation on a patient like that, you want to be able to. Now, developmental dysplasia of the hip. Developmental dysplasia of the hip. So in assessment, when you assess a patient with developmental dysplasia of the hip, there will be uneven gluteal folds and tight creases, deeper on affected side. So I really do wish I could share my screen for those watching me on the other side, but for those on Zoom with me, you can I can share my screen and then you have a look at how this one is or what it is. So let me just share my screen for you now. Okay, so all right, conditions affecting mobility. So let's look at this. This is what I'm talking about. Developmental dysplasia, developmental hip dysplasia, developmental hip dysplasia. So when you assess them, you see unusual traces. Now, let me move on. We have the congenital hip dysplasia. I'm going to move on to the next side of it, but I have more pictures to show you for this condition. So I have limited abduction. There'll be limited abduction of the hip, limited abduction. Remember, we talked about abduction and flexion and adduction. So limited adduction of the hip with pain, and equal knee height and thigh flexion. So when the patient or the child flex their knee and their thigh, it will not be equal. Otolani sign. This is seen in infants less than 4 weeks old. So I have a figure to show you in a little bit. So you place the infant on their back with their legs flexed. Then you click sound head. You hear a click sound. This is when you are assessing the infant. You hear a click sound, and then there will be shortening of the extremities. There will be delay in walking, so limping, lordosis, and waddling gait with all children. So children, mostly developmental hip dysplasia is usually in little children. So the diagnosis that you will see, or the diagnose. How do you diagnose this? There'll be predisposition, there'll be a reason. Intrauterine position, the position that the baby assumed whilst in the stomach. Intrauterine position can affect or can cause developmental hip dysplasia. Gender, so usually this is in females more than men. Hormonal imbalances, we have estrogen. Cultural and environmental influences, some cultures carry their children swaddle against the hip height. This causes a decrease incidence. And usually this is Far Eastern and Africa, the way we carry our kids and we put them on the back and we wrap them. This can cause hip dysplasia. That is culture. That's the cultural wrap of it. So definition is the acetabulum unable to hold firm on the femur. They will have an x-ray that will be done to confirm that this the acetabulum is not well fixed. The femur is not fixed inside the acetabulum. So this call for you to know your bone staff, your musculoskeletal system. So we have the implementation. What will you do for a child that has the developmental hip dysplasia? The implementation will be the newborn. You focus on the newborn to 6 months. So for the first 6 months of life, the intervention would vary by age and the extent of the dysplasia that you have. So they will be reduced by manipulation. So usually they try to do a manipulation to put it back in place. It's just like dislocation. So they'll manipulate it. Splinted with proximal femur centered in the acetabulum in position of flexing. They'll flex the child and then they splint it with a splint to help it stay in place. Then we have the Pavlik harness. This is worn full time for 3 to 6 months until the hip stable for infants that are less than 3 months of age. So if the child is less than 3 months of age, you put the child in the Pavlik harness. So they will keep wearing this until 3 to 6 months. So this is a picture of Pavlik harness. I have the picture on the other side. This is a picture of Pavlik harness. So they want to put the baby inside and then they hook them up. There's one permanent leave, there is one continuous leave for 3 to 6 months before they take it out. Now, this is what happened in hip dysplasia. When the doctor wants to do the assessment, they fold the knees together and they try to put them out, they abduct and adduct to see if they will hear a click. So if the hip socket, this is the head of the femur and it's out of the hip socket. So it's out of the acetabulum. So if it's out of this socket and you are doing it, the bone is rubbing each other. So you're going to hear a click, keep, keep, keep. You'll be hearing that. But looking at this other picture I have, those of you on the recorded video may not see the picture, but for those on the Zoom will be able to see the picture. So for the normal one, you have the head of the femur inserted well inside the hole, but the abnormal one, it is out of the hole. So this is a picture of how the assessment is done. This is how the doctor will do assessment for a baby who has a hip dysplasia. And when they hear the click from this, the diagnosis is made. Sometimes you can obviously see that the skins are folded, usually in girls, baby girls. And it depends, it also affects the positioning of the child, is also a risk factor. So this is a real picture of a baby who is in that. So you can see the traction. Okay, so let's continue with our discussion right now. All right, so give me a minute. Okay. So this is for developmental hip dysplasia. So you want to make sure that child keep wearing that thing for a couple of months. Now let's look at what will you tell the parents? So you tell the parent to move child from one room to another for environmental changes. Don't keep them in one room same time every day. Discuss modification in bathing, dressing, and diapering with the parents. So this is a baby. You want to discuss with the mother how to do all this diaper change and dressing change. Then, since the harness is not to be removed, you sponge bath is recommended. You have to recommend to the mother that they have to sponge bath the baby. Put undershirt under chest straps, and knee socks underfoot, and leg piece to prevent skin irritation. So for the portion of the skin of the baby left, you want to put the socks on that. Then you check the skin areas 2 to 3 times a day. So you're telling the mother how to do all this because it's going to be a couple of months the child is going to have it. So the mother is going to have the baby at home. So you're teaching mommy what to be doing for this baby at home. So you place diaper under straps. So when you put the diaper in, you push it under the straps to make sure it fits well. You avoid use of lotions and powders. Gentle massage skin with the skin under the strap daily. So you push your hand there and you gently massage the baby's skin daily to improve circulation. So you place the diaper, you pad under the strap as needed. So if you feel like you need to put a pad under the strap, you can put a pad under. Then you tell the parent to touch and hold child to express affection and reinforce security. We all understand that newborns need that bond between the mother and the baby. So you encourage the mother to pick the child a couple of times a day to encourage the affection, or to improve the affection between mommy and baby. So 16 to 18 months, gradual reduction by traction and the cast for mobilization. So gradually they remove it 16 to 18 months, and then they try moving it gradually to a traction. Now the older child, if the dysplasia, sometimes it doesn't come right away. Sometimes people start growing, and at a certain age they are not walking, and the problem starts in along the way. It may not be seen obviously from the initial date of birth, but you monitor the child, and you have a child later in their years, like 2 years or 1.5, when they should be running and walking, they are still sitting down. They do assessment to see. So if they figure this out in an older child or somebody who is already walking, you want to provide a preliminary extraction, open reduction, and they have a hip spiker. So the hip spiker is something they wrap around the hips to be able to help them stay in place. So let me just show you an image of a hip spiker right now. So this is a picture of a hip spiker. You can see it here. So this is a picture of a hip spiker. They put it on the hips. It holds basically the hips to keep it in place. So that's what they do for these children. Evaluation. So when you evaluate a child like that, you see the hip joint alignment have been re-established. That's your aim. So your plan was to have the hip joint and the bones aligned well. So now if that has been achieved, that means your evaluation or your interventions were successful. So we have the next reason for evaluation is to have child's growth and developmental needs being met at the right time. So it's not too late. You have realized the problem early, it is worked on. Now let's look at kyphosis, lump on the back, that's the one back. We have the uneven waistline. We have the visualization of deformity that are bent at waist 90 degrees. So let me give you a picture of scoliosis, a picture of scoliosis. So this is a picture of scoliosis. If you bear with me, you see a picture of scoliosis. So this is the normal one. Then you see that this one, it doesn't look normal. A little bent, is not so straight, but this one is all clear. You can see the curve at the waistline. So that's a picture of scoliosis. Then diagnosis. How will you diagnose this child with this problem? So there will be lateral deviation of one or more vertebrae, commonly accompanied by rotationary or motion, rotary motion. So you see that there will be deviation. Instead of having the person be straight, there will be deviation, and then you see one side not symmetrical, to be asymmetrical. Types. We have the functional. We have the flexible deviation that corrects by bending. So flexible deviation correct by bending. Structural, we have the permanent hereditary deviation. So one that you just inherit it and it's deviated. That's how your mother was. So you are born like that. That's the hereditary. Potential nursing diagnosis. The potential nursing diagnosis will be disturbed body image. So you grow up and you are disturbed of your body image. Deficit knowledge about it. So you can use this as a nursing problem. Ineffective therapeutic regimen management, and then impaired physical mobility. So movement becomes a problem with this patient. Implementation, what will you do for them? So you encourage exercise for function type. You teach them isometric exercise to strengthen their abdominal muscles. You teach them isometric exercise to strengthen their abdominal muscle. Then you teach them sit up. That's good exercise to be sitting, sit up exercise. Pelvic tilt exercise, push-ups with pelvic tilt. Then electrostimulation, you teach them surgery, spinal fusion, and Harrington rod insertion. We have the instrumentation with anterior spinal fusion, screw and wires. These are procedures they will take out. Then we have braces. You want to teach them the types of braces we have are the Boston brace, we have the thoracolumbo-sacral orthotic brace, we have nursing care. What will you do for this child or this person? Skin care to pressure areas. So when the patient has braces on, you're worried about the skin under that brace. So you provide skin care, wear t-shirt under brace to minimize skin irritation. There will definitely be skin irritation. So you want to encourage them to wear t-shirts under that to prevent the skin abrasions. Then we have teach them isometric exercise. This you will do as part of your teaching plan. Provide exercise consistent with limitation, yet allow positive peer relationship to promote healthy life support. Don't limit them. Don't tell them you are disabled. Don't go closer to your colleagues. Allow them as much as they can play without limitation on their past. Allow them to be able to mingle with their colleagues and let them have some relationship. Let them develop that kind of acceptance because they already have disturbed body image issue. So evaluation, when you are evaluating this child, you have to evaluate, has the child's lateral deviation of the spine been corrected? So if you put in all these isometric exercise, pelvic tilt exercise, you put in the braces and you keep checking on the child, you want to make sure at a certain time it should start being corrected. Has the child's growth and developmental needs been met? So their developmental needs at this point will be the fact that they cannot move the way they want. So now let's look at club feet. Club feet. That's the Talipes equinovarus. Talipes equinovarus. Club feet. Club feet. I'm going to type it in on the other side for those watching me and can see on the screen. I'm going to type it and you see. So for the club feet, Talipes equinovarus. So this is another name, just in case you go on the NCLEX and they mention this name, you will know what it is. Because NCLEX like to mention names that are not so familiar with you. And then you end up being confused because you don't understand what it is. So this is another name for club feet. So take notes. Assessment, you see a plantar flexion on dorsal flexion. So when the child flex their toes, you see it go apart, like the spider web goes all over, scatter. Then inversion adduction of foreparts of feet. That's it. So it's all curved like this. So you have the child walking and the legs are, usually in my place, they call it bow legs. But the feet, this one has to do with only the feet that are bent this way. So the feet, instead of having it straight, your feet go like this and the toes are all curved. Diagnosis, there will be rigid abnormality of talus bone at birth. So you see this at birth. Does not involve muscles, nerves, or blood vessels. It doesn't involve the muscles. So there's blood flowing all right to the foot. The muscles are all intact, the veins are all intact. It's just a bony deformity. It's the bone inside that is deformed. Excuse me. Then we have implementation. Foot exercise, manipulation of the foot to correct position every 4 hours regularly. So you teach the parent to constantly do that. Cast and splint correction. So they'll put cast or splint to correct the deformity in most cases if it's applied early. So at early age, if they apply it, to be changed every few days for 1 to 2 weeks, then at 1 to 2 weeks intervals to accommodate the infant's growth. So as the child grows, the child keeps going back for them to be adjusting the cast. So if a child has a cast, they adjust the cast 1 to 2 weeks as the child is increasing in size. Surgery is usually required for older children. For children that grow older with it, surgery is required. So that is it with the club fit. That's how you manage it. Now, evaluation, you want to make sure that you have been able to maintain mobility of the foot. Mobility of the foot. So since it's bent like that, it's not normal. You still want to make sure it is easy mobile and has the structure of the foot been corrected. That's a disturbed body image that parents will be more worried about. Now let's look at joint disorders. Joint disorders. When you assess a patient with a joint disorder, what will you see? And what diagnosis will you give? The risk factors for a joint disorder will be increased osteoarthritis. Osteoarthritis. This is usually come with age, obesity, people that are too heavy, trauma to joint due to repetitive use, carpet installer, those that install carpet, they have a problem, construction workers, farmers, sports injuries, people that do sports, they get injuries, joint disorders I'm talking about. Rheumatoid arthritis. Under this, let me talk about rheumatoid arthritis. So rheumatoid arthritis, you want to always make sure you ask a family history. So you question the patient, do you have a family history of rheumatoid arthritis? Gout, you want to assess the patient for obesity, diuretics, family history. These are things you be concerned. Gout, rheumatoid arthritis, family history, obesity, diabetes, diuretics, and family history. Then let's talk about diagnostic testing. So under diagnostic testing, we'll have arthrosynthesis, that's needle puncture of a joint space to remove accumulated fluid. So they will use a needle to puncture into the joint and they try to pull out some fluid. So this one is done under strict aseptic techniques to avoid infection. They do this under strict aseptic techniques to avoid any kind of infection. So usually elastic bandage wrap and joint rest for 24 hours to prevent bleeding. So you have the joint wrapped up with an elastic band and at least for 24 hours. So you keep it on to prevent bleeding. We have arthroscopy, direct visualization of a joint by use of arthroscope. So they use that to view the joint. So local anesthesia is given. You teach them breathing exercise to reduce discomfort. Post-test bulky pressure dressing is applied. So you know that this is going to be a surgical procedure that they use the arthroscope. In a local anesthesia is given to the site. It's not given to the whole body. If the problem is with this hand, they will just give the anesthesia to that site. It's a local anesthesia to numb only that site. And then you will be awake. They don't give a general anesthesia to knock you down. So the potential nursing diagnosis for a patient with joint discomfort is acute and chronic pain. So they usually have acute pain the moment the thing happens. But as years go by, it is joints. Sometimes depending on how old the patient is and how fast the healing process is going. If healing is not so fast, then the patient tends to have a chronic pain because it's not healed. Some of them just have pain and it's always a chronic pain. So they present every time with the same pain. That's a chronic pain for years. Then we have impaired physical mobility. Moving will be a problem, especially if the problem comes to my foot. If I have a problem on my knee joint or my ankle, the problem is like moving will be a problem. So impaired mobility is a question. If it's here, impaired mobility is a problem. If it's here, impaired mobility. Then self-care deficit. If especially your joint is affected. If it's on the hands, if it's on the knees, it affects, and ADLs, activities of daily living, is affected. Ineffective role performance, you can't do what you want to do for yourself so well. So ineffectively, you cannot perform well. Then plan or implementation is the nursing care that you will give. And you also give medications, anti-inflammatory medications to help reduce the inflammation. And also remember, when you are evaluating, your aim is, has the joint mobility been maintained? Have you been able to maintain the patient joints? Are they not easy moving? Are they going easy? Is it good? So the next thing you want to be worried about, has client comfort been maintained? Have they become comfortable? Are they pain-free? Now let's look at 3 disease conditions that I'm going to talk about that are joint disorders that you'll be concerned about. I had mentioned them. I mentioned rheumatoid arthritis, I mentioned arthritis, osteoarthritis, and I mentioned gout. So rheumatoid arthritis or juvenile rheumatoid arthritis, there will be joint pain, swelling, and limitation of movement, contracture deformities, nodules over bony prominences, ulnar deviation, high fever, and rheumatoid rash. You'll have a rash. And particularly this will be seen in the juvenile rheumatoid arthritis. They'll have a serious rash on the skin, on the site. Salmon pink macular rash on chest, thighs, and upper arms. Chest, thighs, and the upper arms. You will see that. Now the diagnosis will be systemic. This is a systemic problem. There'll be bony ankylosis, progressive remission, and exacerbation. Progressively, it will go and always come back. So they will always do a rheumatoid factor to diagnose that, and they'll do a C-reactive protein. They will do aspiration of synovial fluid. They'll put a needle through the joint to pull out the synovial fluid, and they can also do an X-ray to determine inflammation of the joints. Now, the nursing consideration, what will you do? You want to help them with pain management, rest, activities, exercising, weight control if the patient is obese. You also want to give them some warm baths, warm packs, moist compresses, and things that will help relieve pain from the site. So you splint the joint. There's the need to also splint that joint to help with pain. Analgesic, anti-inflammatory, disease-modifying, anti-rheumatoid medications will be ordered to be given. We also have immunosuppressive medication and anti-tumor necrosis drugs that you can give to this patient with rheumatoid and juvenile rheumatoid arthritis. Now let's look at osteoarthritis. There'll be joint pain, swelling, and limitation of movement, contracture deformity, stiffness after rest, Heberdin's nodules, nodes of fingers, and Burkitt's node of hand. So there will be non-systemic. This one is not based on a systemic problem. It's not based on the system. This is non-systemic spare. It's just a spare formation, closure of joint spaces, degenerative, no remission. So no remission means you don't go and come back. It's not something that will start now, reduce, and start again. When you start getting osteoarthritis, it's just like it becomes a chronic problem. So X-ray of the joint will be done, and on the X-ray, there'll be narrowing of the joint spaces. The space between the joints will be narrowed. Then pain management is what you want to focus on: weight control, obesity, anti-inflammatory, and pain medications. Heat application tool is necessary since there's joint swelling and joint pain. Now let's talk about gout. Gout is joint pain, swelling, limitation of movement, contracture deformity, and tophi. So in gout, we have the tophi in there. So we have the systemic disturbed purine metabolism that will give you the purinic taste or smell. So tophi formation is deposit of urates in joints. Deposit when urates are deposited in joints. Urate are byproduct when they're deposited in joints, and there will be exacerbation. If you have gout, you always get exacerbation. There will be X-ray, blood tests will show. They'll do blood tests for WBCs, then erythrocyte sedimentation rate. They'll do uric acid levels and synovial fluid aspiration. So sometimes they will have to tap into the synovial joint. They will do tapping, especially if the knees or the joint are swelled up. They will pull out the fluid. They put a needle in there and then they pull it out. So there'll be pain management. Diet. You avoid meat rich in purines. Meats that are rich in purines, such as organ meat and sardines, fish, alcohol, ketoacidosis, dehydration, analgesics, and aspirin medications for gout. These are the nursing considerations. So you want to teach them about alcohol use. You want to teach them about dehydration. You want to teach them to avoid meats that are high in purines. Then let's look at Piaget disease. Piaget's disease. Then when you assess a patient who has Piaget's disease, you see pain, bow legs that are decreased height, shortened trunk with long appearing arms, enlarged scalp, long bone, spine, and rib pain. You see kyphosis, pathologic fractures. When you assess them, you see pathologic fractures. The diagnosis is unknown cause. We don't know what caused that. Excessive bone resorption, that's too much bone loss in this Piaget disease. It occurs more often in older adults. And when you are implementing care for them, you want to administer pain medication, and then you encourage the patient to rest. You also want to help prevent fractures by using safety precautions. Remember, they say pathological fractures, you want to use safety precautions. Then you want to administer medications, calcitonin, that's bisphosphonates, alendronate, that's fosamax, and pamidronate. These are medications you will administer to help with calcitonin. When you evaluating a patient with that, you have the client, you have to ask yourself, if the patient is going to be in pain with pathological fractures and you are administering all these bone pain medications, you want to ask, has there been comfort? Have I been able to maintain comfort for this patient? That's what your aim should be, nursing a patient like that. And then you also want to ask if you have been able to prevent complications from this. So the other condition I'm going to talk about under conditions that limit mobility is bursitis. Bursitis. When you assess a patient with bursitis, you see decreased mobility, especially in adduction. There'll be decreased mobility when the patient adducts. Then when you diagnose him, what will you see, or what is going to be done? What nursing diagnosis will you give to this patient? Your definition of the nursing diagnosis will be inflammation of connective tissue sac, that's between muscle, tendon, and bones. Particularly, this affects shoulders, elbows, and knees. Particularly, it affects the elbows, the shoulders, and the knees. That's bursitis, inflammation of the bursalis. So potential nursing diagnosis will be acute or chronic pain. You are worried about pain, so the patient can have acute or chronic pain. There will be impaired physical mobility and then self-care deficit. So because the patient is impaired in moving, remember we are talking about conditions that limit mobility, conditions that will limit the patient from moving around. So our next thing will be implementation. What will you do for this patient? You want to help them with bed rest. So you want to help them with enough rest, not to stay in bed all day, but you help with rest in between activities. You assist them to perform daily activities or activities of daily living. You assist in injecting. These people get cortisone, they get steroid injection to the site. So if the problem is on this joint that is always being the problem, they start giving the cortisone to that joint site. Usually you see that done on the knees as well. Then we have heat application, and then you give them muscle relaxant because this one make them feel tight in their joint. So you want to give them muscle relaxant. Then we have evaluation. So when you are taking care of a patient with this problem and you are evaluating them, you want to make sure that you were focused on pain management and reducing inflammation and mobility. So since this is about conditions that will limit the patient from moving, you want to focus on whether you have been able to help the patient move. Has there been relief in pain, any comfort? That's your main thing. Now let's talk about osteoporosis. Osteoporosis. We know this one is usually in the older women after menopause. They start getting bone mineral depletion. Their bones start reducing in function. So when you assess, you see decrease in height. So you see the older women or the older people start reducing in height. Then low back pain, especially hips and spine, kyphosis. There'll be kyphosis. Diagnosis, when you are diagnosing a patient, what are your nursing diagnoses? What will you be concerned as the registered nurse for this patient? Reduction in bone mass with no changes in the mineral composition. You are worried about reduction in bone mass with no changes in mineral composition. It's been reduced, the bone mass, the weight is coming down. Degenerative disease that are characterized by general loss of bone density and tensile strength. The bone doesn't have any more strength. This is diagnosed by the bone mineral density. They do a bone mineral density test, and they expect a score not less than or equal to 2.5. It will indicate osteoporosis. So a score that is less than 2.5 from 2. That is less or equal to 2.5 is indicating that the patient has osteoporosis. They want the score to be higher. So that's why they do the bone mineral density. Then we have the risk factors, the age related. Mostly 60 years and above are at risk for osteoporosis. Small framed and lean body build, those with very tiny and lean body building makeup. Caucasian or Asian race. This is racial thing too as well. So for the Asian people or the Caucasians, they have that risk. So you want to take note. Inadequate intake of calcium or vitamin D. So besides race and besides your age, if you don't take enough calcium or vitamin D, you're at risk. Postmenopausal, I mentioned that before. Immobility and sedentary life, those who don't move around, they don't do any exercise. They are just always at one place, every day, every time. Alcohol intake, high alcohol intake, too much of alcohol. When you drink too much alcohol, you are at risk for osteoporosis. Then we have prolonged use of steroids. So when you use too much of steroid, we know steroid will help cause bone demineralization, so bone depletion. So you want to minimize steroid use or prolonged use of steroid. Now, implementation or the plan is diet high in calcium and vitamin D. You encourage weight bearing on long bones. You encourage them to bear weight on long bones. You also want to help prevent falls. That's what you want to do. That's your plan as the nurse. They shouldn't fall. Physiotherapy. Then safety precaution measurement to prevent pathological fractures. You use back brace or splint for support. Then you use bed boards or hard mattresses. You administer medications, calcitonin, calcitonin, and all those bone mineral medications. So you try to administer that to minimize the rate of depletion or bone destruction. When you're evaluating a patient, your question should be, have you been able to maintain mobility? And does the client know about dietary requirement for osteoporosis? So take note, disease conditions that I'm mentioning under this, your aim is pain management. Your aim is pain management. You are trying to manage their pain. Osteomyelitis. The next condition is osteomyelitis. It's a disease problem that limits a patient from moving. It limits mobility. So osteomyelitis. When you assess a patient, your main concern will be pain. There'll be swelling, redness, warmth on the affected area. So there'll be fever, elevated white blood cells, positive culture and sensitivity, positive, or they do x-ray of the affected side, they will see a deformity. Now the diagnosis, what will you see? There will be infection of the bone. So this is infection of the bone. Osteomyelitis is infection of the bone, usually caused by Staphylococcus aureus, and is carried by the blood from a primary source of infection or from direct invasion. An example is orthopedic surgery or orthopedic surgical procedure or a fracture. So when you get a fracture, you're at risk for osteomyelitis. You're at risk for osteomyelitis. That's an infection of the bone. So when you get a surgical procedure done or you have a fracture, you are at risk for this condition. So the risk factors will be poorly nourished, elderly, obesity, impaired immune system. If your immunity is impaired, you are at risk. Long-term steroid use. Potential nursing diagnosis will be acute pain, definitely. If your bone is infected, bone infection, you will have pain. Ineffective bone tissue perfusion. The bone is not able to do its exchange well, so you have bone tissue perfusion ineffective. Injury, risk for deficit, and then deficit knowledge. If you don't know too much about how to take care of yourself. These are potential nursing diagnosis: acute pain, injury, deficit knowledge, and ineffective bone tissue perfusion. Implementation, what will you do? What is your plan as the nurse? What will you plan to do for this patient? You have to teach the patient the risk factors for osteomyelitis and then joint prosthesis. And you have to give them pain medication. You know their problem at this point is pain management. So you teach them pain medication, you give them pain medication, and then you support the extremities with a splint, a pillow when they are in bed to help with body alignment, to help reduce the pain. You provide cool environment and lightweight clothing. Don't let them go and wear some heavy clothing on themselves, putting more weight on the affected site. So you avoid exercise and heat application to the affected site. So under this one, you have to avoid heat. Remember all the other conditions I've talked about, you use heat on the site. With osteomyelitis, you don't use heat. It's infection of the bone. So it will be seen in blood cultures and all those blood work that they would do. There'll be white blood cell elevation. So you provide diversionary activities. And then asepsis with wound care. You have to do cleaning. You have to do wound dressing. High protein diet is recommended to help with healing. Then you instruct about home care and wound care and antibiotic administration. You have to let the patient know they have to take antibiotics for a while to help clear out the infection, which will be ordered for them as well. So for patients that have risk or problems that will limit their mobility, these are things you want to be concerned about, because if you are not able to tackle these conditions as they are, on the NCLEX, they want to know if you will be able to help them or if you can manage a patient with such a problem. So your evaluation, your aim should be to maintain comfort again and avoid complications. Now let's look at osteomalacia. Osteomalacia, this is bone pain and tenderness. When you assess, you see the pain and tenderness to the site. There'll be muscle weakness and Bowlegs kyphosis. X-ray will show porous bone to show the bone is porous. Now diagnosis will be decalcification of the bone. So if you are assessing, this is how you diagnose it as a nurse. That means you need to know what is going on. So you have seen this, you have assessed the patient, you have seen the you have seen the Bowlegs, and you have seen that there is tenderness to the site. So you will need to diagnose the patient. So this decalcification of bone due to inadequate intake of vitamin D, absence of exposure to sunlight, or intestinal malabsorption, chronic kidney disease, there is potential nursing diagnosis, and this one will be injury, risk for injury. Then there will be delayed growth development. This is osteomalacia. This is osteomalacia. Osteomyelitis was infection of the bone after a patient gets a surgery or has a fracture. Then let's look at the implementation for osteomalacia. What will you do? what is your plan as the nurse? You have been able to assess and you find out the problems. You have been able to diagnose the patient. You know that the potential problem is risk for injury and growth development delay. Then you have to administer pain medication. Pain management is crucial. Increase sun exposure. Remember, when you were diagnosing, you realized that the cause of this osteomalacia is because there's not enough exposure to sunlight. So you start thinking vitamin D, you start thinking calcium, you start thinking of ultraviolet radiations, things that you expose the patient to this. Then you assist the patient with activities of daily living to prevent pathological fractures. And then your evaluation is to help the client to have pain reduced for the client and to also help with mobility. Now let's look at spinal bifida or neural tube defects. This is another problem that limits mobility. This is another problem that can limit patient with mobility. So we have, when you assess a patient with spinal bifida or neural tube defect, there will be dimpling at the site of the spine occult, spinal occult. I don't know if you have ever seen this problem before, but usually you will see this in newborns, spinal bifida. When they are born, you see a little bump on their spine, or you see that the spine did not close well during formation. So it creates a deviation. So you have the spine going this way, and then at a point, this one is not there. So from here to here, there's space. It's a congenital birth defect though. Bulging. So some of them will have the tissues, the tissues or the meninges, the tissues around the bulge out. So it will push out and then there'll be a little bump. So instead of having the spine go straight, then there's a little bump there. There will be bulging sac-like lesion filled with spinal fluid and covered with a thin, atrophic, bluish, ulcerated skin. That's the meningocele cell. So you see the meninges will pop out. It will be like a leather ball. I don't know if you have ever seen it, but I have seen it before. I've taken care of pediatrics with that problem. So we also have the hydrocephalus, which is an increased risk for people, paralysis of lower extremities. So when you have something bulging out of your back, you cannot walk, you have a problem walking. Mostly birth defect, as I mentioned, they sometimes do a surgery for the newborns who survive it, and they do the surgery after 3 months of birth so that they try to correct it. But mostly such people will have paralysis for life. They will have paralysis of the lower extremities. Musculoskeletal deformity, there will be club feet, dislocated hips, and kyphosis scoliosis. Neurogenic bladder and bowel, prolapse rectum. They'll have bladder problem because remember the problem started from their spine. So for those on the other side, let me just show you a picture of how this will look. I have seen it before. This is how it will look. So you have the spine that is supposed to be normal and closed like this. Here you have a break. There is nothing here. That's created a hole. This was done during the formation of the child. Now, when that happened, there is bulging, there's meninges here, and the cerebrospinal fluid is flowing through this line. So if the cerebrospinal fluid is flowing and supplying these things, and it comes here, there's nothing to supply, it pushes and forms a bulge. That becomes the meningocele. So the meninges will form like a little notch here on its own. And then it bumps up, and all the meninges that were supposed to go up straight, they all push inside and it becomes soft. And that's how it is. Let's continue. Now, when you are diagnosing a patient with this problem, what will you see? There'll be congenital anomaly of the spinal cord by non-union. That's the one I just showed you the picture. It will not be connected. It will be bulge. There'll be a bulge out of the meninges. Then the risk factors will be maternal folic acid deficiency. So usually they're related to the age of the mother. If the mother was old and the mother did not have enough folic acid to form the baby, usually maternal age is a risk factor for this. It's a birth defect, congenital birth defect. So folic acid during pregnancy is needed. Previous pregnancy affected by neural tube. So if you have a risk, if you have had a child previously with that problem, you are at risk. The cause is combination of unknown genetic and environmental factors. It's unknown. Nobody knows what causes it. Advanced maternal age, I mentioned that already. High levels of alpha-fetoprotein or amniocentesis. So when they keep going, they're digging into your amniotic fluid. Okay, let's talk about the implementation. What will it do? Occulta. So no treatment. We have the meningocell, myelomeningocell. This is surgical repair at 24 to 48 hours after delivery. Myelomeningocell. They try to push this back. They try to fix it within 24 to 48 hours. You observe for irritation, CSF leakage, cerebrospinal fluid leakage, and signs of infection, hydrocephalus. You maintain optimum aseptic techniques. You cover lesions with moist sterile dressing. You position the client on abdomen or semi-prone with sandbags. Don't put the child on top of it on the back. No, you have to put them semi-prone or in a prone position. You have to check for abnormal movement of extremities, absent or abnormal reflexes, incontinence, fecal impaction, flaccid paralysis of lower extremities. So you are concerned about the lower part if the effect is on the spine to the lower side. So you observe for symptoms of meningeal irritation or meningitis. So you know meningitis will come with a stiff neck and all that bad back symptoms. So you observe for that symptoms. Then you provide frequent source of stimulation appropriate for child's age level. So you don't still want to ignore the age level of the child. So you provide the appropriate stimulation. Then you focus on postoperative observation on detecting signs of meningitis, shock, intracranial pressure, and respiratory difficulty. So you want to make sure you monitor the patient's fontanelles. So usually, like I said, it will always be in a child, and that you take notice of. So fostering parental bonding. So you have to encourage the mother to constantly be in touch with the child. You perform family teaching on how to care for children at home, discuss with family referrals for physical therapy, orthopedics, procedure, bladder, and bowel management. Then evaluation, you have complications. You want to ask yourself, have there been complications avoided? Is the patient free from meningitis? Is the patient getting better? Has infant physical needs been met? Now let's talk about hydrocephalus. This one has to do with frontal occipital circumferential increase in abnormality, fast rate. So you see this one, the baby's occiput, it's bigger than normal. So the splint sutures and widen distended tense fontanelles. So you see the fontanelles all bulge up. It's like the head is just abnormally bigger than its size. So there'll be sunset eyes. You see the eyes is all like this, and you see the head abnormally big. Irritability, the child is irritable, the child is like upset, I would say. Unusual somnolence, you can't console such children, they cry, they have a high-pitched cry, they are always crying, you can't console them. Convulsions, they can also have convulsions. So sometimes they put a tube in there to be draining the cerebrospinal fluid, to be draining the fluid, the CSF fluid from the fontanelles, because all that place is a hole when the child is born. So because of that, all the spinal fluid move from down and then it come and accumulate there, because there's a space in the hydrocephalus, means accumulation of fluid. Hydro, we know about water already. So that's cerebrospinal hydrocephalus for us. Now the diagnosis will be congenital or acquired condition characterized by an increase in accumulation of CSF within the ventricular system and subsequent increase in ventricular pressure. The causes is neoplasm, aqueductal stenosis, congenital cyst, vascular malformation. The types communicating due to increased production of CSF or impaired absorption. Non-communicating due to obstruction, blockage, and circulation between ventricles and subarachnoid spaces. The implementation will be operative management. Usually they do operation for that. And the ventricular drainage will provide external drainage for the fluid, like I had explained. So you observe the shunt if it's functioning well. So you observe for increased intracranial pressure and for signs of shunt infection. That's irritability, lethargy, and high-pitched cry in the child. Post-operatively, you position on unoperated side in the flat position. Do not hold infant with head elevated. We don't want their head elevated. We position them flat. Position them flat in a flat position. Then shunt needs to be modified as child grows. So as the child is growing, those children, they usually stay in the hospital for a long time. So you talk about discharge planning and referral to specialties. Then you teach the parent about increased risk lethargies if myelomeningocele present. Now, evaluation will be if the child has obtained optimal growth and developmental function. If the child has obtained optimal and developmental function. So let's talk about neuromuscular disorders. Neuromuscular disorders that will limit mobility. So we are still under physiological integrity, conditions that limit mobility. So let's see, we are almost done. These are the last part of it. So let's talk about neuromuscular disorders, assessment and diagnosis. I have the table of neuromuscular disorders. I have cerebral palsy and muscular atrophy. So assessment, when a patient has cerebral palsy, what will you see? You see arthritosis, spasticity, rigidity, ataxia, atonicity, repetitive involuntary slow gross movement, repetitive involuntary slow gross movement. In a neonate, in a child, they cannot hold up their head. They are feeble, they cry, inability to feed, body noticeably ached or limped. They'll be limping. Then infant, they'll have failure to thrive syndrome. For toddlers, preschoolers, they'll have mental retardation. Toddlers and preschoolers with cerebral palsy, they'll have mental retardation and delayed physical development. Now let's look at muscle atrophy. So muscle weakness, lordosis, scoliosis, waddling gait, there'll be joint contractures, stumbling and falling. So patients with muscle dystrophy, that's what they will have. They'll be stumbling and they'll be falling, they'll be wobbling. Analysis. So if you are analyzing a patient with cerebral palsy, you will see voluntary muscles poorly controlled due to brain damage. So this is in the cerebra, it's not coordinating well. So because of that, voluntary muscles will not be coordinating well. So something you are supposed to voluntarily do, it's not coordinating well. It's just not speaking well. So the cause is unknown. It's not clear what caused it. Predisposition is prematurity. So if the child is born premature, there's existing prenatal brain abnormalities, trauma, anorexia, or infection at the time of birth, it can affect the function of the child's brain. And then the treatment is ambulation devices, surgical lengthening of heels, cord to promote stability and function. Medications are to give muscle relaxants, baclofen, and interstitial pain pumps, medications on the pump. So this is how you analyze a patient, or you try to manage a patient. Potential nursing diagnosis will be nutrition, that is less than body requirements, self-care deficit, impaired physical mobility, delayed growth and development for a child with cerebral palsy. So for a child with muscular dystrophy, there will be progressive muscular weakness, atrophy or voluntary muscle, no nerve effects. Your nerves will not be affected, and this is usually genetic. That one is more of genetic. The diagnostic test they will do is creatinine phosphokinase, abnormal electrocardiogram, that's EC, electromyogram, then abnormal muscle biopsy. They do biopsy of your muscle. Predisposition is hereditary, it's progressive, is terminal, and the treatment is intensive physical therapy. Active and passive range of motion, I have talked about that. Light spinal braces or long-term braces may help with ambulation. Now, your potential nursing diagnosis will be self-care deficit, compromised family coping, they'll have difficulty coping with this, impaired physical mobility, and delayed growth. Now, under implementation of cerebral palsy, you want to assist with early diagnosis, assist with physical and occupational therapy, give referrals to appropriate agencies. You provide emotional support to the parents and the client. You assist with feeding, you place the food at back of mouth or either side of the tongue towards the cheek. You helping the patient or the child to eat. And you never tilt the head backward when you are feeding them. This can lead to choking. Muscular dystrophy. This one, when you are managing them, you want to promote safety and avoid slips and falls. So you know it's all about their muscles. So you want to make sure they don't fall. So they use braces or use a wheelchair. You assist with diagnostic tests and then client-parent education. So you need to educate the parent about the cause of the disease condition. Now let's talk about disease. Let me see what's next. So the next condition I'll talk about is myasthenia gravis. Myasthenia gravis. Myasthenia gravis. Promote family understanding of the disease. This is part of managing a patient. This is the problem. It is neither a central nervous system or a peripheral nervous system disease. This myasthenia gravis. There is no muscular atrophy or loss of sensation. It is not hereditary. Nobody knows what caused this particular condition. But in this condition, you want to administer anticholinergics, anticholinesterase, corticosteroids, and immunosuppressants. So this is also another condition of the muscles that prevents movement or that will impede mobility. So good eye care, artificial eye tears may be ordered, maintain optimal mobility. And then client teaching, you want to teach the importance of taking medication because you have to order immunosuppressants because they don't know what causes the muscles to just start losing its function. Then they wear a medic alert band, and then avoid factors that may precipitate myasthenia crisis. Example is infection, emotional stress, upset, use of streptomycin or neomycin. They produce muscular weakness. So medications that will produce muscle weakness, you avoid them. The alert of myasthenia crisis. So myasthenia crisis is sudden inability to swallow. You cannot swallow food all of a sudden, inability to speak or maintain a patent airway. So you have to be alert. This is a airway issue. Now, multiple sclerosis, you teach relaxation and coordination exercise. You teach progressive resistance range of motion, administer medication, immunosuppressants, corticosteroid, antispasmodics that causes spasms of the muscles, and then use weight bracelet and cuffs to stabilize upper extremities. Bladder and bowel training is necessary. Sometimes the patient will need a Foley catheter inserted. Then they will need eye patch for diplopia. You help them with device use, self-help, you teach them as well. No tetracycline or neomycin is given because they increase muscle weakness. So when it comes to neuro stuff with muscles, you want to stop the patient from taking neomycin and streptomycin. They can increase muscle weakness. Then you want to refer them as necessary as possible to the Multiple Sclerosis Society. These are support groups that they can go to find people in the same category of sickness. Now, the evaluation is to maintain independent functioning, have the client physical need been met? That's your question. So I think I'm probably going to talk about the last condition here, and that is amyotrophic lateral sclerosis, Lou Gehrig disease, Lou Gehrig disease, amyotrophic lateral sclerosis. So let me just share my screen and you see the spelling of this disease, amyotrophic lateral sclerosis, Lou Gehrig disease. Take notice of this particular name, Lou Gehrig disease. NCLEX would like to dig into that. When you assess a patient with this problem, there will be tongue fatigue. Their tongue is tired, atrophy, and fasciculation. That's brief muscle twitching. The tongue is twitching. The tongue is not stable. It's not controlled. Nasal quality to speech, dysarthria, dysphagia, aspiration. These are their problems. When you assess, you find that. Then progressive muscular weakness and muscle wasting, atrophy, spasticity, usually begins in upper extremity, distal portion affected first, and then fasciculation. Emotional liability, cognitive dysfunction, respiratory insufficiency usually cause death, and no alteration in autonomic, sensory, mental function. There's no autonomy. Diagnosis. Then you want to when you diagnose this patient as a nurse, there will be progressive degenerative disease involving the lower motor neurons. So this is what amyotrophic lateral sclerosis is that you need to know. So knowing that gives you the reason to understand what to do for the patient. So you have to understand that this amyotrophic lateral sclerosis is progressive degenerative disease that involve lower motor neurons of the spinal cord and cerebral cortex. The voluntary motor system is particularly involved with progressive degeneration of the corticospinal tract, and it leads to a mixture of spastic and atrophic changes in cranial and spinal musculature. So there is no specific pattern that exists. Involvement may vary in different parts of the same area. Involvement may vary different parts of the same area. There will be possible etiologies, and the possible causes will be genetic, family, chronic, which is viral infection, chronic and slow, which can be as a result of a viral infection, autoimmune disease, environmental factors, plan or implementation, what you will do for this patient. You have to apply principles of care of client with progressive terminal disease. It's progressive and terminal. You cannot heal it. You can just manage the patient. You treat self-care deficit symptoms, maintain adequate nutrition, physical therapy, or speech therapy is needed, adaptive home equipment. So things patients will need in the house to live comfortably. Then you want to also provide psychosocial support to the child or to the patient and the family. They need support. So when you are evaluating this patient, your aim for this plan will be, is the client able to maintain optimal physical functioning for as long as possible? Has client comfort been maintained? That's what you want to ask yourself. So I'm going to stop here, and I'm just going to give you a recap of what we have learned. I'm going to mention the disease conditions just in case you didn't get it right. So I have been talking about physiological integrity. I've been talking about basic care and comfort and the physiological integrity. And the condition, I'm talking about conditions that limit a patient's mobility. You need to know some of them, you need to know all of them for NCLEX. So I talked about herniated intervertebral disc. Herniated intervertebral disc. I spoke about developmental dysplasia of the hip, developmental hip dysplasia. I did show images under that to show you what it is. And I talked about club foot, Talipes equinovarus. I spoke about club feet. I spoke about joint disorders, disorders in your joints that will affect mobility. I spoke about rheumatoid arthritis, juvenile rheumatoid arthritis. I spoke about osteoarthritis and gout. I spoke about Piaget's disease, P-A-G-E-T '(S) disease. I spoke about Piaget's disease. Then I spoke about bursitis. I spoke about osteoporosis. Remember, age is part of this. Then I spoke about spinal bifida. Yes, osteoporosis, spinal bifida. This is neural tube defect. I spoke about hydrocephalus. I spoke about neuromuscular disorders. So under neuromuscular disorders, I spoke about cerebral palsy. I spoke about muscular dystrophy. Muscular dystrophy, cerebral palsy. I spoke about the two. And then I spoke about, give me a minute. Did I miss Bell's palsy? Yes. So I spoke about amyotrophic lateral sclerosis. One portion I see that I didn't mention was Parkinson's disease. Okay. So Parkinson's disease is part of diseases that prevent nerve impulse transmission. So under Parkinson's disease, you see them shaking and shaking and shaking. So you encourage finger exercise, encourage them to play a piano. That will help with coordination, range of motion. You teach the client ambulation modification and you refer them to physical therapy. You teach them about goose stepping walk with side base. Teach them to concentrate on swinging arms while walking. They turn around slowly using small steps. Teach them, promote family understanding of the disease as you educate the patient and the family as well. Sight and hearing to interact. I think that was what I jumped. Then you refer the patient to speech therapy and you administer dopaminergic medications. That's dopamine, Sinemet, anticholinergics, benztropine. You want to give that to the patient with Parkinson's disease. So after that, I spoke about myasthenia gravis. I also spoke about multiple sclerosis. And these are the conditions I have been talking about, and physiological integrity, basic care and comfort. And my topic was conditions that affect mobility. This is the second video under physiologic integrity. The first video was mobility and immobility. And I spoke about mobility and immobility. I spoke about the devices that you use for that and the movement. So I'm going to come your way. And the next video under physiologic integrity is going to be interventions to promote comfort. What will you do for a patient with who need comfort, who need basic care of comfort? What will you do for them? Interventions the nurse will do to promote comfort. These are things from the NCLEX test plan. This is from the test plan. So you want to take note that these things I'm teaching are not straight from content. That's why I don't go into detail with the content. I go into assessment, what you will see, and when you are managing the patient, what you will do, and education, what you will tell them. So this is how NCLEX will frame the question. So take note, these are from the test plan. They want you to know these things before you step in to take the exam. So I'm going to see you in the next video, and do have a good day. Thank you for watching. You can repeat the video at any time, and you can follow up and let me know if you have any questions. Thank you again, and goodbye.